Hello, my name is Sarah Beheimer, and today I'm here to discuss with you the topic of syphilis. Here is a brief overview of the points I'll be covering in today's presentation. Syphilis is a localized and systemic disease caused by the bacteria Treponema pallidum, a spirochete or corkscrew-shaped organism. There are four main routes of transmission and also four different stages of infection. The most common mode of transmission is via sexual contact. Other routes include perinatal transmission, in which the infection passes from the mother to the fetus via the placenta. Some uncommon modes of transmission include receiving infected blood or contact with an infectious lesion on broken skin. The four stages of syphilis are primary, secondary, latent, and tertiary. Each stage has a different timeline and distinct set of symptoms. The presentation of primary syphilis involves the formation of a painless ulcer, called a chancre, at the point of inoculation or introduction. The ulcer can be single or multiple and is usually round and firm. These ulcers resolve without treatment. However, treatment would prevent progression to secondary syphilis. Secondary syphilis is classified by systemic symptoms following the spread of bacteria through the blood. Constitutional symptoms such as fever, fatigue, and headache may be present. Specific symptoms often include a maculopapular rash that presents on the palms and soles in addition to the trunk and extremities. Condyloma lata, which are highly infectious wart-like erosions, can be found in the anogenital region or oral mucosa. In latent syphilis, a person will present as asymptomatic despite having positive serology. The latent stage is split into early and late phases. Early latent is defined as less than 2 years after initial infection. This stage is still infectious, and up to 25% of people can develop a recurrent secondary infection. Late latent, however, is less infectious. While latent syphilis may last for many years, without treatment, 15 to 40% of people can progress to a tertiary infection. Tertiary or late syphilis can be divided into three main forms: gummatous, late neuro, and cardiovascular. Gummas are non-cancerous granulomatous lesions with a necrotic center found on the skin, internal organs, and/or bone. Gummas found in the central nervous system classify the disease as stage 4 or neurosyphilis. Neurosyphilis can occur earlier in the stage, presenting as asymptomatic or in the form of syphilitic meningitis. It can also manifest later, within 1 to 10 years after initial infection, as meningovascular syphilis, characterized by stroke, cranial nerve palsies, and spinal cord inflammation. Other manifestations include general paresis and tabes dorsalis. Tabes dorsalis is a myelopathy specific to syphilis that occurs approximately 25 to 30 years after the initial infection. It causes a loss in sensation, primarily in the lower extremities, a sharp pain in the legs and abdomen, and a broad-based ataxia. Both general paresis and tabes dorsalis may present with another classic manifestation of neurosyphilis, Argyll-Robertson pupil. This presents as a bilateral meiosis or pupillar constriction, where the pupils are able to accommodate but do not react to direct or indirect light. Cardiovascular syphilis usually presents 10 to 30 years following the initial infection. Treponema-induced inflammation, or syphilitic aortitis, is inflammation that leads to the eventual cessation of blood supply to the aorta, which causes smooth muscle death and can progress to dilation of the aorta, an aortic aneurysm. Congenital syphilis infections before 2 years of age are classified as early congenital. A newborn may be asymptomatic and only identified as having syphilis from routine prenatal screening. If not identified and treated, they can develop poor feeding and the snuffles, which is runny white or bloody discharge from the nose that contains spirochetes. Features can also include an enlarged liver, jaundice, a maculopapular rash on palms and soles, skeletal abnormalities, and non-tender generalized lymphadenopathy. The onset of congenital syphilis after 2 years is called late congenital and differs in presentation. Some of the classic symptoms include notched, widely spaced teeth called Hutchinson's teeth, saber shins characterized by anterior bowing of the tibia, saddle nose deformity, perioral fissures, which are cracks or scars near the corners of the mouth or nose, and interstitial keratitis of the eye, which results from inflammation of the cornea. Children may also suffer from a variety of neurological symptoms such as deafness, intellectual disability, or cranial nerve palsies. There are two main ways to look for syphilis: serologically by checking the blood, or direct detection under a microscope. Serological tests can be further divided into non-treponemal and treponemal tests. Non-treponemal tests are indicated for screening, evaluating disease activity, or evaluating the response to treatment, as they are sensitive but not specific. A rapid plasma antigen is the test of choice. A venereal disease research laboratory is especially useful for evaluating neurological involvement by checking the cerebrospinal fluid. Positive tests will be followed up by a treponemal test. Treponemal tests are confirmatory tests that detect antibodies specific to treponemal antigens. The two commonly used tests are the treponema pallidum particle agglutination and the fluorescent treponemal antibody absorption test. When a specimen can be obtained, such as from a condyloma or chancre, a direct test can be done to detect primary and secondary syphilis. While a direct test can confirm a diagnosis, negative results do not rule one out. Available direct tests include dark field microscopy, which may be combined with immunofluorescence and allows for visualization of the spirochetes. A PCR may also be used to amplify genetic material and detect the presence of specific syphilis genes. When looking at the cases of reported syphilis, we can analyze the characteristics of those affected. The rate of reported primary and secondary cases of syphilis among men was much higher than the rate of cases among women. Most primary and secondary cases come from the MSM, or male/sex of males, community, and 2018 accounted for 48.2% of all reported cases and 77.6% of male cases. The rates of reported primary and secondary cases were highest among individuals aged 25 to 29. The highest rates among men also belong to this age group. In females, the highest rates belong to those aged 20 to 24. As the data demonstrates, we can generally expect to see the rate of cases highest among those who are the most sexually active. The total rate of reported cases of primary and secondary syphilis in the United States and outlying areas was 10.8 per 100,000 in 2018, a 14.9% increase from the previous year. The data from 2018 shows that the rate of reported primary and secondary syphilis cases was highest amongst Blacks. The greatest rate increase from the previous year was 40.9, however, among American Indians and Alaska Natives. Reported cases of primary and secondary syphilis continue to be seen with a high rate of HIV co-infection. In 2018, 41.6% of reported cases with known HIV status were among MSM. There was an increase of 39.7% in reported cases of congenital syphilis from 2017 to 2018. This increase has paralleled the increases in primary and secondary syphilis among all women and those of reproductive age. Considering the statistics on the previous slides, we'll now discuss some groups of interest at high risk for contracting syphilis. But first, here are some general risk factors. The primary risk groups for syphilis include MSM as well as men or women who are HIV positive. The secondary high-risk group includes those who have been incarcerated, sex workers, young men under 29, as well as members of certain racial groups. Prevention should always start with adequate patient education, informing patients about safe sex practices and the dangers of sexually transmitted infections. Abstinence is backed by the CDC as the, quote, surest way to avoid transmission of sexually transmitted diseases, end quote. There is no effective vaccine for the prevention of syphilis, but there are measures individuals can take to lower but not eliminate the risk of transmission during sex. Condoms, when used consistently and correctly, can reduce the risk of transmission when the infected area or sites of possible exposure are protected. Care must be taken, however, if there is an infectious lesion outside of the protected area that can still allow for transmission. Looking at the two highest risk groups, we can follow the CDC recommendations for prevention and control of syphilis. It is important to take a complete sexual history for an at-risk patient. CDC recommended tests should be ordered based on different parameters such as age, gender, sex and/or gender of sexual partners, risk, and anatomic sites of exposure. A syphilis test should be given to sexually active MSM and HIV-positive patients at least once a year and as often as every 3 months in some cases, such as those with multiple sex partners or substance use. As syphilis is a notifiable disease, positive cases should be reported to the CDC. Patients should be encouraged to discuss their status with their partners so that they may seek care. The steps to reducing congenital syphilis are similar. Physicians should complete a sexual history with patients, including STI counseling for those at risk for sexually transmitted infections and contraceptive counseling for those at risk of an unintentional pregnancy. All pregnant women should be tested for syphilis at the first prenatal visit or as soon as the pregnancy is confirmed, and again at delivery. Any woman with confirmed or suspected syphilis should be treated, as well as the infected woman's sex partners, to avoid reinfection. Women who deliver a stillborn infant should be tested. All cases of syphilis should be treated and reported by the stage to the local or state health department ASAP. Congenital cases should be reported within 24 hours. Another part of prevention and control of infectious spread is treatment. When treating primary, secondary, or early latent syphilis, a single intramuscular dose of benzathine penicillin G is sufficient. For late latent, tertiary, or unknown date of transmission, intramuscular injections should be weekly over a 3-week period. Cases of neurosyphilis should be treated with intravenous penicillin G for 10 to 14 days. Those who are allergic to penicillin may be treated with doxycycline or ceftriaxone. In the cases of both neurosyphilis and pregnancy, patients should be desensitized to and treated with penicillin. Sexual contacts of the patient should also be treated. I'll now wrap things up with a brief summary. Today I discussed the various features of a syphilis infection, including a brief background, who's at risk, how it spreads, and the expected symptoms. I also talked about the different ways an infection is diagnosed and how it can be treated to prevent progression to latent and tertiary stages. Here are my references that helped me in putting together this presentation. Thank you for your attention, and if you have any questions, feel free to email me at the address on your screen. Thank you.